إذا أخذنا this condition, there is an increase in TSH and decrease in T4T3. So start with T4T3. There is reduction. This is hypothyroidism. Wake up. You go to the TSH. TSH is increased. Then that means what? The problem is in the end organ, which is the thyroid. So this is a primary hypothyroidism. Now the last scenario is an increase in T4T3 with a decrease in TSH. Increase T4T3 is hyperthyroidism with a decrease in TSH, then this is most likely a negative feedback. So this is a primary hyperthyroidism. Did you understand? Okay. When you go to the clinical thing, there's another test that we use commonly to further explain things, which is called the radioisotope or radioiodine uptake test. I'm not going to go through it, but it makes your life even much easier to differentiate between these conditions. This is the major use of TSH. The other thing that we use TSH for is actually the monitoring of the replacement therapy adequacy. Which means what? We take the level of TSH. We have in our minds a desire, a wanted TSH level at a point, at any time point. What we measure is the TSH later on, after the treatment. Now, if the TSH level was much higher than the desired TSH, what do you think this could be related to? I'm doing a replacement therapy. I'm replacing the thyroid hormone by giving the thyroid hormone to the patient. Okay, so in a non-sufficient replacement, please. Okay, exactly. So there is no enough feedback inhibition to the TSH, and that's why the TSH is much higher than the desired TSH. What else? What else?
Hyperpituitarism. Hyperpituitarism. ممكن تصير.
There is a problem in the pituitary. That's right. Another thing, which is important. مين حدا عنده patient ياخذ thyroid hormone؟ تاخذ كل يوم؟ The problem of thyroid hormone replacement therapy is that you have to take it forever, for life. And there is too much, there is a high percentage of patients who are so poorly compliant on the medication. We're going to mention in a minute why. And that's why one differential diagnosis in the case of increased TSH level above the desired level is that there is what? Poor compliance. Now, on the other hand, if you have a decreased TSH even further than the desired level you wanted, then this is mostly related to
increase in thyroid replacement.
Over replacement. You are giving way too much of the thyroid hormone. Did you get it? Okay. Now we will get to the thyroid replacement therapy. Now, luckily enough, we have the target hormone, which is the thyroxine, being available as an oral medication. And that's why this is the most commonly used drug in the replacement of thyroid problems. It's the actual thyroid hormone. Okay? And the drug we give is called Levothyroxine. Levothyroxine is a synthetic preparation of T4. I'm supposing you know all these things. The name. Where should we use it? In the cases of hypothyroidism. Makes sense. It's a lifelong therapy. Okay? Particularly with certain cases of hypothyroidism where you cannot reverse the problem. Like what? Exactly. When you just remove the thyroid. Okay? So the only choice to do is to replace it with levothyroxine. Now, the strange thing is that we could use it also for goiter. What's goiter?
Enlargement.
Why would you use thyroxine for the goiter? Although goiter most commonly is related to an increased production. Exactly. So this is what we want. Goiter that is related to much increased levels and activity activity and production and whatever you want of TSH. So you give levothyroxine just in the concept of negative feedback regulation. You want to inhibit the production of TSH, decrease its effect on the thyroid, and the thyroid will just go back or regress in the size and functionality just after the treatment of levothyroxine. Okay? But it's given orally, and it's the only drug in this particular axis to be given orally, but it could also be given in an injectable form, particularly when we have emergency conditions related to hypothyroidism. But there are certain things you have to know about levothyroxine. The first thing is that after you give it orally, you will expect it to go down your intestine to be absorbed. The absorption is good, well enough. Okay? But there are several factors to take into account about the absorption of levothyroxine. There's a little bit too much interference with its absorption, particularly with food, in any kind of food. Okay? And basically the people who eat a lot of fiber diet, the absorption of levothyroxine is not that great. And the other thing are the calcium supplements, things that are absorbed at that local area. Calcium supplements, magnesium and aluminum antacids. So what should you do to the patient? There's too much interference with absorption. Second, so just give it at an empty stomach. And that's why people just take it in the morning, early morning, at an empty stomach without, like, half an hour to 1 hour before taking your first meal. Some people might not like it. So what do you do?
Compliance.
Just give it very late in the night, okay? At bedtime, before the patient sleeps, but given, or supposedly that the patient will not eat for 3 to 4 hours. Okay, so it's gone into the intestine, it was absorbed, it will go into your blood. What's the first thing to think about when it goes to the blood? The binding to the plasma proteins. And most of that is bound to the thyroxine binding globulin, could be also bound to albumin, and this happens in about 99%. Again, just keep in mind that any condition that will change the level of the thyroxine binding globulin would change the level of your drug in your in the blood. Now, why do we care about that? What if there's too much protein and there's too much binding?
بطل effective within the boundary.
Exactly. Because for the drug to be effective, or even the hormone, the actual hormone, to be effective, it has to dissociate from its binding globulin and go into the tissue. So it's only metabolically active once it's free. And there's another level of organization for that, which is what? That the T4 has to be transactivated into a more potent form, which is the T3, and that needs what?
Enzyme.
An enzyme. And that enzyme is tissue specific. So there are certain tissues that have too much of this enzyme. Like what? Like the liver. Okay? So too much of this preferred conversion happens within the liver. This enzyme is the 5'-deiodinase. طيب خلصنا ومشيت الحال ومشيت الامور. What's next? The metabolism. We finished the absorption, we finished the distribution, and now we get to the metabolism. Now, the thyroxine or the thyroid hormones are metabolized mainly in the liver, which means what?
Cytochrome B450.
The
Drug interactions.
cytochrome 450 microsomal enzyme. But why do we care about that? Because there is too much drug-drug interaction, whether with the inhibitors of that system or inducers of that system. Okay? And this is not easy to deal with. Certain drugs have to be withheld, have to be modified in their dosage to accommodate this level of T4. Okay? Now, once it's metabolized within the liver by the microsomal system, it just goes into the urine to be excreted by the kidney. Okay? So we care about the kidney function also for the elimination of the drug. Some of it will go eliminated in the stool, okay? But it's not a very high percentage. Now, the thing you have to know is that it has the half-life of elimination is very long, okay? And it depends on the functionality of the thyroid, whether you're thyroid, hypo, or hyperthyroid. But in general, what we do because of this long half-life elimination, we just give the drug once daily, okay? Which again makes it a little bit easier for the patient to accept. But because it's a lifelong treatment, this might have or manifest as poor compliance. But finally, levothyroxine side effects. What could these be? One word.
Metabolism disturbance.
Hyperthyroidism.
Hyperthyroidism.
You're replacing something, okay? You might give it too much, that you will get into a state of hyperthyroidism with all its signs and symptoms. You should know these now, okay? And sometimes you might get into a severe state of hyperthyroidism that needs medical attention. Okay, so the levels have to be monitored using what? TSH. That's when we need the TSH levels, the desired TSH level above which and below which we could decide whether the dose is over or under replacing the condition. Yes. So there's a protocol for that. The first time we do it like after 1 month, but later on, once we get to the desired level of the thyroxine, you just monitor it every 6 months to 1 year, okay? Depending on the patient's response. Now, some patients will come to you too much complaining of signs of hyperthyroidism. So instead of monitoring them every 6 months, I have to do re-evaluation, okay? So it depends on the
لما يكون عندي هايبوثايروديزم لما اعطي الدرج هياثر على الفري ولا هياثر على البروتين باوند
على both. You are giving the drug, okay? There is not too much free or bound because there is not too much production of thyroid. So you're giving the drug and it's going to take the regular, normal life pattern of thyroid. It will go protein bound and then it will start getting free to have an effect. Something important about thyroxine, two important things. One, it's safe in pregnancy. So patients or pregnant women have to be continued on the thyroxine replacement. And sometimes we even need to increase the dose of thyroxine. Why?
Increase demand.
The basal metabolic rate is increased. So to maintain that level, you have to increase the level of the thyroxine. The other thing, when do you, or when are you afraid of thyroxine? What does it cause that might be, or that might kill the patient?
Heart failure.
Exactly. So any patient with a compromised cardiac function. You remember last year when we talked about the heart failure. I told you that sometimes the problem is not related to the heart, but there's too much increased demand, like in the cases of thyrotoxicosis, hyperthyroidism, that the body is producing for giving you too much thyroxine. The basal metabolic rate is increased so much, the heart cannot understand this increase in the demand, so it will get into a failure state. That's why elderly patients, about 50 years, even if they have a regular normal cardiac function, we always start with lower doses of the thyroxine and start going up, okay? And you might need to maintain them on the low doses of thyroxine. Did you get it? Now, the anti-thyroid drugs we will discuss are very simple. I will go over the normal life cycle of the thyroxine in your body, or the thyroid hormones in your body, just to remind you how we use that in pharmacology. So, We have the thyroid follicle. You have that in close contact to the colloid that has what? Thyroglobulin. And it's in close relation to the blood. You have the iodide, which comes to your blood, and it's selectively uptaken by the
Sodium iodide.
thyroid, the thyroid follicle. Why? Because there is a specific, it's important, which is the sodium iodide.
Yes, embarrass.
The sodium iodide symptom. So there's an active transport of iodide from the blood into the follicle. This is active. It needs energy. Okay. After that, the iodide will be what? Oxidized using the enzyme peroxidase to produce iodine. Okay. Now iodine will go into the follicles. Colloid to start iodinating the thyroglobulin particles, particularly on the tyrosine residues. Okay, so there's the iodination of thyroglobulin. As you can see here, we could have one iodide, so that will produce the MID, or two iodines on the thyroglobulin, that's DIT. The next step will be coupling. Coupling of these MID DITs. Now, if you have two DIT, you will have a T4. If you have one MIT, one DIT, you just ask them. اتفرج علي أول مرة صراحة. سامعين ما أنا حكيت؟
Yes,
Okay. So that will lead to
T3, T4.
Now, T3, T4 step-bound to thyroglobulin will need to be proteolytically cleaved to be released into the blood as free hormone. Once they get into the blood, what's going to happen? They will need to be carried by the tyrosine-binding globulin and other drugs. Why am I going through all this? Because antithyroid drugs will act on these things. And the first line of treatment that's related to this cycle is something called the radioactive iodine, the I-131. Now, why do you think this is helpful in treating a thyroid disease?
Decrease iodine
أول
production.
شيء كلمة iodine, just keep in mind that there is a selective uptake by the thyroid. So whatever you give, it will go to the thyroid, most likely. The other thing is that we are using a radioactive.
Killing.
So it will start, once it gets into the thyroid follicle, it will start destructing that. Okay? Something called the beta isotopes. Okay? Or radioisotopes. This is what happens. Selective uptake into destruction of the follicle. How do we give it to the patient? You just give it to your patient in a very small amount of solution. You ask them to drink it, and you're almost guaranteed that it will go most likely into the thyroid, and it will exert its effect. The problem will be what? Later on, what's going to happen? Now, regularly, what?
Hypothyroidism.
No, let's wait. Regularly, the state that the patient will get in is that the radioactive material has to be eliminated from his body, right? So it takes a few weeks. And that's why you have to ask your patient, you cannot get pregnant in the next 6 months. You might ask your patient even not to have sex in the next month, and to keep close monitoring of his own items and so on. Okay? So it's a little bit difficult. Now the other thing is that you will get destruction of the thyroid, which will lead to a state of hypothyroidism. So what do you need to do?
Replacement therapy.
Treat them with thyroid. Okay. The first thing is that we might use in the diagnostic techniques a different isotope, not an 130. There's 125, 127, and so on. The dosing is different, and so the uptake into the thyroid would be a little bit different. Okay? But particularly it's the isotope. The second kind or second class of drugs we use are the Thionamides. Thionamides, we have two drugs. PTU, which is propyl thiouracil, and methimazole. the other. So, now, what do they function in? The great thing about this drug is that it will target multiple levels of the thyroid hormone synthesis procedure. It will start by targeting the peroxidase. So if you inhibit the peroxidase, you are inhibiting the oxidation and the iodination steps. Okay? And what's going to follow is that you won't have enough MIT-DIT, and that will lead to less coupling, so less hormone production. Now, there's another thing that's related to very high doses of propylthiouracil, is that it could even go down into the peripheral tissue-specific 5' deiodine. What's going to happen due to that?
ما في T3. ما في
No. Decreased T3 production. Because this is the peripheral conversion between 4 and 3. So there's less potent T4 and the effects will be less. What's the problem with this? I mean, in clinical practice, you are giving a drug, it's going to target all these steps, less thyroid production. What could be a problem here? The thing is that you are targeting the iodination steps, the oxidation steps. But what about what's already there? And there is enough thyroglobulin, there is enough iodine from the previous state, and there is enough T4 and T3 production. So that's why the clinical effect, to get a desired clinical effect, it might take some time, okay, until the thyroglobulin scores are depleted. So there's a delayed clinical effect. The other thing which is bad about them is that they have short half-life, particularly the PTU, which means that you need to use it more than 3 times a day, or 2 to 3 times a day. Okay? So what might happen also is a relapse. Okay? If you do not continue the drug on a regular basis, and if you do not give it the right administration intervals, you might get a relapse, artificial relapse. Okay? Returning of the problem. Now, there's something funny about these two drugs. You have to know, okay? The side effects, the most commonly encountered side effect is very simple. It's called a maculopapular rash. Okay? Rash, simple, it's rash. That's in almost 90% of the cases. You do not get anything else. The only thing that you have to take into account is that this PTU has been recently reported by the FDA in a very, very strong language. It was the first time that the FDA provides such a strong statement that PTU is linked to serious liver toxicity and liver injury. So you might need to stop and not give PTU to patients who are prone to liver or they have liver problems. That was not the case with methylazone. And that's why, in general practice, what do you prefer to use? Methylazone. Actually, it's better because there is no liver toxicity, and it's better because actually it has a longer half-life, so it could be used less frequently. But there's a problem. The problem is in the pregnant woman. With the pregnant woman, PTU was found to be much safer than methylazone. Okay? And that's related to the plasma protein binding. But whatever. The general practice, methylazone is first line. Unless she's pregnant, then you have to think about PTU. Final antithyroid drug is iodine. Okay, why would giving iodine lead to antithyroid function? Iodine is needed in the synthesis, right? So it will do that just if you give it too much. Supraphysiologic levels of iodine might lead to what? To inhibition of the process. How? You're just overloading the system. The peroxidase enzyme is not going to be enough to do the oxidation, the iodination, all these things. Okay? So if you give it acutely, there's something called in clinical setting, the acute Wolff-Chaikoff effect. These two scientists were just doing experiment. It was recently. And their experiment was just to expose the rats or the animals to too much iodine, infusion of iodine. And what they found is that there is a sudden reduction in the level of the thyroxine hormone production. I'm saying acute. So does that mean there is...
لا مرة واحدة بس يعني مرة واحدة طبعا مش دائما مش maintenance.
Wait, we gave it too much. There's acute Wolff-Chaikoff effect, less thyroxine production. Why I'm saying it acute? Because it actually happens, and then there is something called the escape phenomenon. Yeah, the patient at one day today, I'm giving him the too much iodine, whether supplement by orally, it's actually we have drops, or in the emergency we have something called Lugol's solution, which is iodine plus iodine. Anyway, you're exposing the thyroid to too much iodine, it led to the inhibition of the cells. 10 days, and the effect will be gone. Why?
Compensatory. Increase peroxidase.
أهم من إنه نزيد الأكسجين. Remember what I said. There is an active symporter at the basolateral membrane of the thyroid. So simply the thyroid just gets, what the hell? Why am I expressing this? Just take the symporter out of the way, down-regulate the symporter, and the iodine that you are giving is going to be ineffective. It's not going to get into the thyroid. So the function will come back to normal. Did you get it? So the thyroid gets bored, it got sick of too much iodine, it down-regulated the symporter, there is not too much entry of iodine into the thyroid, and it will start the regular process of synthesis again. When do you need to indicate that? When is it indicated? Actually, it's given in the acute emergency condition. Like you have something called thyroid storm or the acute severe thyrotoxicosis. You need a one-shot reduction in the thyroid hormone synthesis in the ER. Just give them this injection. And you might even give it by drops later on for maintenance. Again, it's just in life-threatening fatal thyrotoxicosis. The other thing that they use it is that they use it pre-operatively. هلا شو في مشكلة مع الثايرويد بالسيرجري؟ سمعتوا عنها مرة. Related to anatomy of physiology. Thyroid is so freaking vascular. And لما فوق سنة 5 ورابعة سنة أنا شفت أكثر من إنه when they open up any kind of injury, you will get just a sprout of blood coming into your face. And that's why one thing pre-operatively, they try to decrease the vascularity, okay, and the functionality of the gland, so to reduce the risk of bleeding during the operation. Such iodine is going to be effective for such reasons. طيب. Yes, please.
دكتور الايودايد لما نتوما انت قلت ان البيروكسيديز ما راح يستخدمونها نتوما. طب ليش البيروكسيديز ما يستخدم بس الريجولار دوز اللي هو متعود عليها؟
تمام هو بيستخدمها بس انت you will feel that there is a reduction in the production of.
ليش الريجولار؟ هي رجع عندي الايودايد نفسه.
لأنه enzymes when they are exhausted they get out of function. This is something known. When you oversaturate the enzyme, it's going to stop functioning. Okay? And that's why it just needs to stop this over exposure to iodine, and that's by the inhibition of the symptom. But you are right. Finally, which is something commonly used for the thyroid thyrotoxicosis patients, we need to give a symptomatic relief. What do you think the symptoms and signs of thyroid are related to? So yes, about what do you think the signs and symptoms of thyroid problems are related to? Thyrotoxicosis. احكي بقى. Great. Yeah. Great. So most of the problematic signs and symptoms are related to this to the upregulation of the beta receptor. So what do you do to just relieve the symptoms?
Beta blocker.
Okay. Do we give it all the time? Not really. So there are certain cases when you do not have too much symptomatology of hyper or hypothyroidism. We're talking here about hyper. And that's something called subclinic. Anyway, when the symptoms are too much and they are bothering the patient too much, you will and you should start thinking about using a symptomatic lever, and this is particularly done by blocking the beta adrenergic receptor. بتذكر شو ما قلت لكم انه في beta 1 selective, في non selective, في ones with a symptomatic activity, في ones with alpha beta. ولا مش فاكرين شيء؟
لا متذكرين.
What do you prefer to use in such thing?
Beta 1 blocker. Beta 1 blocker.
Beta 1 selective. Okay. One with non selective. شو بدك تستخدم؟ selective ولا لا؟ يا زلمه شيء. هون شباب. What do you prefer? Selective or non-selective? Selective. Okay. Can anyone defend the idea of selective? Why?
لأنه
مشاكل تكون في القلب.
أنت بدك إياه على بيتا 2؟
مصيبة.
على بيتا 1.
بتموت.
Okay.
لأنه thyroid hormones increase the production of beta 1 adrenergic receptors particularly مش اثنين بس beta 1.
Okay. But do they skip the beta 2?
No, but minimally.
Do you know that there is tremor? Where is or what's tremor mediated by?
Beta 2 بس minimally.
So yes, most of the problem is related to beta 1, which is the cardiac problems, palpitations and
Increased cardiac
other
output.
kinds of tachycardia and maybe myoclonic arrhythmia. But there are other problems: the nervousness, the tremor, and all these things. You might need to inhibit the beta 2 also. So what we use regularly is propranolol, which is Enderal, which is a non-selective beta inhibitor. The important thing is not to use a beta blocker with an intrinsic sympathomimetic activity. If you remember what we talked about that. But anyway, you use a non-selective beta antagonist without any intrinsic sympathomimetic activity. And, okay, what's a major contraindication for this drug? Yes, asthma. This is something. What else?
Respiratory problems.
أي respiratory problems.
Respiratory problems. Kidney problems.
If there is too much compromised heart function, you have to be worried about using the propellant. So, okay, I have this problem. What should I use instead? Give me one choice that could replace the beta 2, the beta
Renin-angiotensin
in the cases of asthma.
Renin-angiotensin inhibitors أو RAS inhibitors.
راس لا ما بظبطش. راس inhibitor شو دخلوا too much sympathetic. عشان ما فيش. So the major problem is in the heart. And the heart is causing me the palpitations, the arrhythmias, and all these things. I cannot use the
Alpha agonist.
Yes.
Which type? Which type? Do you remember I gave you the type? The dihydropyridines, which act peripherally, are not going to be effective. What we need is a calcium channel blocker that acts particularly on the heart, cardiac inhibitory ones, such as diltiazem and